Lumbar ASD is a problem. Every fourth or fifth patient that we see in our clinic is a case of ASD. So it's a problem, it's a challenge. And managing this with minimal access is very interesting. It's a new era. So this patient, this lady is a very unfortunate lady. She has symptoms of canal stenosis. On top of it, she has buckling in her knees. She has significant paresthesia which is ever progressive for the last 6 months. She is tired of spine surgeries. A tsunami after tsunami has hit her in the past. In very recent past, one after the other, she has been having a series of surgeries, right from lower down, higher up. I don't know which was fused when. At the end of it, the last surgeon had a thought in his mind that, he thought an interspinous device would probably prevent her from having an ASD again, but in vain. So this lady continued to have problem, and now the diagnosis is basically a stenosis higher up, and which explains all her symptoms, including the buckling of the knees. She is very, very upset with spine surgeons. She wants surgery, but she wants it MIS only. And somehow she located me. She came from somewhere else, and probably I thought there is a solution to this. So what I did was, I'll go to the clinical picture. So this was where the coflex was. We removed the coflex from here through a small incision, which is the superior part of the old incision. We removed it, we decompressed that particular level. We put guide wires higher up. So we wanted to extend it to T10. So we put guide wires higher up, lower down, included 3 more levels. Then how do you connect with the lower rod? We didn't want to open that part. So this is what we did. So we passed the rod underneath after the screws were put, and so this was the end result. So these were the scars to put the upper screws. This was the scars through which we connected this particular rod with the previous rod using domino, and this was unexposed. This is a part which was exposed only to decompress the highermost level, and she was very happy. So again, as I said, it's very interesting to manage ASD with minimal access. So that was a relatively fresh case which broke down, and this was a lady whom I operated long back. She was operated for a L4-5 listhesis with stenosis. Now she comes with a very severely symptomatic ASD at L3-4. Extremely obese, a BMI of about 40. So look at this. It's broken here at L3-4. And there is severe stenosis. This was the well decompressed previous level, and I didn't want to open her. In obese patients, I refuse open surgeries even if they plead. So again, through the same incision, we just extended probably by a centimeter. See, if you are operating on these lordotic levels, you can actually do 3 levels with the same incision. See, look at the trajectories. So firing your arrows in different directions to the same from one point. So that's what was done. So this was a rolled construct. So we extended up. This screw was a bit medial, but it was not symptomatic. So we took that opportunity to correct it. So guide wires to the same hole, paraspinal holes, a TLIF, extended it. So it is possible to deal with ASDs with MIS. Another technique, so this was a lady, this is published about, I think 2017. This was a lady who came from a West African country, and she had this fixed. So that it was very, very difficult. We had to basically extend her higher up and lower down. She had stenosis higher up and lower down. She's extremely obese. So then, I was not very sure about MIS. What we did here was, it was very difficult to remove this innies and outies. It was a very different mechanism that they had used. So what we did was, so you see, this is what was done. That particular segment was bypassed. So we extended up, did a posterolateral there, extended it down, did a TLIF at this point, and connected with the longer rod. At that point of time, we were not very conscious about multi-rod technique, which is currently being used everywhere and anywhere. So this we adapted in another patient who had a stenosis higher up, L3-4 and L5-S1. So you bypass this particular area, and that serves a lot. It decreases your operative time, that decompresses this particular level. You don't have to take the burden of this particular level in your fusion. Similar to an osteotomy, a satellite rod that is used to protect an osteotomy. So these short rods protect the osteotomy and they don't stress the long rods. So that was the principle that we use. So we presented this a few minutes back. So we have classified this management of ASD with MIS using 4 techniques. Suppose the first 1A and 1B is a situation where that adjacent level, the primary level is solidly fused. You are not bothered about it. So the next level is involved. So we remove the rod, we remove the screws through the same incision and forget about it and do a TLIF at the adjacent level. You should make sure that your the primary level is very well fused and solid. Then comes the rod. The second is wherein it may be difficult to remove the lower screws. The upper screws will try hard, work hard on them and remove them, but just leave the lower screws unattended and do a adjacent level fusion using the same incision, probably extended by a few centimeters. Third is where the lower level was very recently fixed, or whether it is unstable, or whether there is some degree of deformity for which that level has to be incorporated in the segment, in the construct. So guide wires again, 2-level TLIF and connect with the rod on both sides. So this is where we bypass the level above and level below. Now this was a patient who rapidly developed ASD, operated somewhere else. So rapidly developed ASD at an adjacent level within 3 months. So there are situations where you don't need to stabilize higher up. It looked perfectly stable. I'm contemplating just a decompression here. See, the thing is, this patient was unnecessarily fused. So avoiding a ASD is also, managing ASD. So this patient was unnecessary. This was a stable level to go with. If you go back, it was a very stable level. They could have just done a decompression here. So I'm contemplating the patient just seen me. I'm going to just do a MED at this particular level. Again, another patient who had a TLIF done lower down with Steffi, long back. He had a migrated disc higher up. So why fuse the adjacent level? Just put a tube in, excise it. So ASD is a burning problem. There is an increasing interest in MIS, as you see here. We have MIS solutions for primary problems, but there is very limited literature on MIS solutions for revisions, especially ASD. So this presentation probably fills that vacuum. Thank you.